Hello, everyone. This is Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and this is EP Talk, where emergency physicians come to talk about things that are relevant to our professional practice as well as our personal lives. And I'm here today at ACEP 2019 in Denver, Colorado, with Steve Michalik of Biofire. And I've been watching the company for quite some time, and I'm intrigued by what you guys do. And I want you to kind of put it in your own words. You're the guy from the company.
Sure.
Let's talk about what is it exactly that Biofire adds to the emergency physician's repertoire? What can we do? What do we need Biofire?
Sure. Well, first, thanks for having me.
Okay.
Biofire is the leader in infectious disease testing, and we coined the term syndromic testing. And so what do we mean by that? When I talk to people, a lot of them are like,
right.
We're not sure what syndromic testing
right.
is. So in the past, we have taken like a onesie, twosie approach to testing.
I have to test for strep screen. I have to test for flu. I have to test for this. I've got to go down the list and do all the various things.
So we thought, well, there's a better, more efficient way to do this.
Why not a comprehensive test?
Exactly. So what we've done is we've created panels. We have 5 FDA-approved panels, each for a different syndrome.
Right.
And we put the most likely pathogens that cause those particular syndromes on these panels.
Okay.
So a good example would be our meningitis encephalitis panel.
Okay.
We have 14 different viral and bacterial targets on there.
Okay.
And imagine if you wanted to test 14 different targets in the lab. First of all, you wouldn't have enough CSF, cerebral spinal fluid, to run those tests.
Right.
In this case, you'd need 200 microliters of material.
Right.
And in an hour, you would be able to test 14 different things and either quickly rule them in or rule them out. And ruling them out, actually, as we've talked about before, ruling them out may be as important as ruling them in. Absolutely. So the negative predictive value of these tests is really important, because you might find as a doc that you're going down a path that, this is not a little unusual, not what I was my first knee-jerk thought was.
Right. And as therapies become more and more expensive, we're talking about cost efficiency as well as time spent in the hospital or the ICU.
Right.
Getting to the diagnosis quicker, which is more likely for the patient to have a better outcome. So we've always known that it's better to treat the specific problem than to shotgun and go after something generally. But of course, most of the time we've dealt with cultures and smears, and cultures, as we know, take days.
There's not only do they take days, but depending on the syndrome, a good example, our new panel is the pneumo panel. And I think it was in 2015, there was a really nice CDC-funded review article that was done, and it was one of the most highly curated publications on pneumonia. And what they found is that culture, I don't remember the exact numbers, but like a third, almost a half of the time, those cultures come back negative.
Right.
And you have no idea what you're dealing with.
Right.
So when you look at culture relative to our pneumonia panel, it's not unusual that we get about 25-35% more positives, where you'll have a pneumo panel positive, culture negative test, and now you're getting information you wouldn't have.
Right, and you know from the outset what antibiotics, what therapies are most likely to be effective. You're not in the dark. Yeah, I can see the benefit for that.
I should add, depending on the panel and the syndrome, some of those targets are for antimicrobial resistance genes.
Right.
So that really helps in terms of targeting the right therapy.
And obviously, in this day and age, the last thing you need to do is go down a pathway of treatment using an antibiotic that you find out is not effective.
Right.
I mean, this is economics. You know, if you've got a patient in the ICU who's spending $1,000 a day and it takes you 3 or 4 days to finally determine that it's not going to work.
Yeah, I would say one of the biggest trends today is diagnostic stewardship, right? And so you hear a lot now about the right test on the right patient at the right time. And admittedly, our tests are expensive, but what they're allowing you to do is, I think docs are able to oftentimes, do I admit this patient or not?
Right.
Is this a patient I need to isolate or not?
Right.
What are the cost savings on the back end?
Right.
And also time to effective therapy.
Right.
There's a lot of publications. We have
Sure.
250 peer-reviewed publications, and it's been shown that these tests really do significantly shorten that time to effective therapy.
That's great. That's great.
At the end of the day, I feel we add a lot of value to
great.
Patients and outcomes and such.
Well, this is a great introduction. We're going to talk actually in more detail in a further podcast at EP Talk. I'll show you the ad. You'll see this in Emergency Physicians Monthly, and y'all, I'm sure a lot of you like me looked at it and said, "What is Biofire? That's a nice name. I like it." But what exactly are they adding to my practice? And I think that as we discuss this in a more long-form podcast, watch for it on EPMmonthly.com. And I'll be discussing with some of your experts and, more importantly, some of the clinicians, some of the emergency physicians who have actually had clinical experience with the Biofire panel.
Absolutely.
And that's most important. I want to hear what my colleagues have to say about using this. And if they say, "Hey, this really helped me out. This saved the patient days of illness, cost, and we got to the diagnosis a lot faster," then this is something I want to do.
Sure. Well, thank you. I encourage listeners to swing by our booth. One of our founding core values of our company is to have fun, and that hopefully that shows in our advertisements and when you swing by the booth. So
keep your eyes open on EPMonthly.com, and thanks for joining us today. Hello, everyone. I'm Mark Plaster, the Senior Executive Editor of Emergency Physicians Monthly, and this is EP Talk, where emergency physicians come to talk about things that are important to us professionally, sometimes as well as personally. And today, my guest here today is Bill Weiss.
That's right.
Karl Storz, and we are at ACEP 2019 in Denver, Colorado. And thank you for coming out. We're just going to talk a few minutes.
Thank you, Mark.
About Karl Storz and some things that people might not really understand, Karl, because your brand has been associated for a long time with optics and
it is.
A lot of other things. But you're doing more than that now.
We are. Matter of fact, next year is our 75th anniversary as a company. We're privately held from a little town called Tuttlingen, Germany. And so we go way back as a general surgery, ENT, urology company. We do things in neurosurgery that are just amazing. But we've always been an optical company with companion instrumentation.
Right. I mean, Karl
that's who we are.
Has been advertising with EP Monthly for 25 years.
So we are, though, people don't realize, the originator of the video laryngoscope. So there's a doctor at Cedars-Sinai in L.A. named George Bursey that decided to put a camera on a video laryngoscope back in the mid-'90s. Okay. And we launched our first video laryngoscope in around 2000. We came out with our CMAC brand around 2009. And so we've built now a brand in the anesthesia space around intubation and airway management that includes one of the most popular platforms on the market.
Absolutely.
And it
when we started doing video laryngoscope, it changed the way I did business. I know that.
It does. And it works very well for our emergency physicians because we still have endoscopy, right? So we have otoscopes, nasal scopes, cystoscopes. But from the same platform monitor, you can use flexible intubation scopes. You can use rigid, single-use, reusable. Our platform is very versatile. And so for the emergency physician, having a highly mobile battery-run monitor system that lets all these different scopes plug in is great value to the hospital.
You're not digging out a different scope for every different function that you might need to have.
You don't.
While you might have most of us now have video laryngoscopes. We might not have some of the other applications, and having a single platform might give you the opportunity to say, we can do this if we have this additional add-on.
As long as you have that monitor, the options really open up.
That's right.
If you go digital, we have otoscopes that plug in. We have nasal scopes that plug in. We have cystoscopes. We have rigid scopes. You put a camera, an endoscopic camera, on our monitor with a standard eyepiece, and you could put any rigid scope that you want. So if you're doing forward body removal, for example, our rigid bronch line has a standard eyepiece, it's called, that hooks up to an endoscopic camera. So having the monitor is the key to success in our mind. Right. It opens up the optics of Karl Storz to you.
You made your name on those optics.
Absolutely.
And now with the digital platform allows something that I'm sure you're doing is to allow someone to watch what the operator is doing at a distance, even around the world, possibly.
Absolutely, you can. So, from an education standpoint, from being able to, with our blades, do a direct laryngoscopy versus video at the same time. A lot of educators will turn that monitor around, make them do it direct while they're coaching and capturing the image and then walking them through the video. Here's what I liked. Here's what I didn't like. Here's what you did well, what you didn't do well. So from a telehealth standpoint, from a clinical standpoint, from a value standpoint for the hospital administration, it's the most cost-effective way to go.
You don't know, but I actually am involved in the building of multiple hospitals in Africa.
Okay.
And one of the things that we have really emphasized is the idea of education. It's one thing to have Western doctors step in and do things, but it's a better thing to actually be able to teach someone or to coach someone, not necessarily they may know how to do it, and to coach someone, give them the confidence of having someone just watching what they're doing.
Mm-hmm.
So that's right.
You bet.
And with a digital platform offered with something like this, the ability to expand care in low-resource areas of the world is expanded dramatically.
And it's just not complicated. And so, from an education standpoint,
that's
right? We have a blue button. You hit the blue button, it starts your video.
Yeah.
Right. So it's just easy. You could replay it on the same monitor. You can take it off an SD card, put it on a laptop, walk people through it, and hand them an educational experience. It doesn't cost you much, and it's not complicated.
That's great. It's great talking to you, Bill, and it's nice to know that this optics are known the world over for the finest optics around, and for this company to have built, to continue to innovate and to add new services and new products on top of something that is absolutely world-renowned.
Thank you.
Encouraging, and it's something that we're happy to be a part of. So
thank you. We're proud of it, Mark. We appreciate it.
If you haven't tried out the Karl Storz instrument, you need to. It's an old name. It's been around a long, long time for a good reason. And it's something that you really owe it to yourself. And it might be the thing that opens up some new services, not only in your emergency department, but if you, like me, are involved in care in remote places, either in the United States or abroad, it will give you an opportunity to expand that education and
Thank you.
Experience.
Well, we appreciate the opportunity to speak about our company. We're really proud of it. We enjoy it. Thank you very much.
Thanks. Hello, everyone. This is Mark Plaster from Emergency Physicians Monthly, and I'm here at ACEP 2019 with Dr. It's great to have you. Thank you so much for having us. Appreciate it. Good. Tell me, you and I have gotten to know each other through your work with Bill.
Right.
But obviously you've been an emergency physician for a long time. You know the ins and outs of what it is to do quality emergency medicine and how that affects our ability to be compensated. You and I talked about, not too long ago, about doctors that become psychologists. And tell me what you were meaning by that.
Well, the new modern emergency medicine record is full of menus, and things that you've got to click on and read and translate. And what we are trying to do is get them out of that genre and to go back to dictating.
Telling the story that we discussed was the idea of you want the payer to understand how much effort you put into this chart. They have to understand your thought process.
They do, and the doctors have to understand these payers and coders of your chart do not know medicine. They know billing. They know the rules of billing, and we're also trying to incorporate the rules of billing to the doctor so he can dictate the proper way to let these billers understand the situation. Medical necessity. Many doctors have just gone away from it. They don't understand what they need. Well, medical necessity is always a patient there in the emergency room.
It seems rather obvious,
absolutely,
doesn't it? And most of the time, they're there in emergency because they think, from a layperson standard, they believe that something's wrong. Wrong. Sometimes desperately wrong. It may not, in the end, be desperately wrong, but they don't know that.
They don't know that, and the doctor needs to translate that on the record and say, this patient came in with chest pain. They may have gone home with dyspepsia.
Yeah.
But they came in with chest pain, which is a legitimate reason to be in the emergency department, a legitimate reason to code it a high record of reimbursement. And I think a lot of these younger doctors especially have kind of lost they're not teaching that anymore. And they don't know how to tell the patient's story. And just let your dictation and your record be a guide for anyone that wants to read it in the future as to why the patient's there, what you ordered, what you did for them, how you treated it, and what was your disposition, and why did you do it.
Technology has really changed that because you and I are old enough to remember when dictation was not very good and it was very expensive.
Right.
Okay, we just recorded it and somebody had to go in there and type it out.
Correct.
And so we moved away from that to standardized charts, templates, clicking on phrases, this, that, and the other.
Exactly.
And while we were doing that, dictation really grew up.
It did.
It really grew up, and it can pick out language. Accents, all kinds of things.
Medical terminologies improved dramatically. It's all improved a whole lot. Dragon systems have grown with us as well.
Yeah.
And with that, we have an opportunity to get away from the computer and looking at the computer all the time.
Yeah.
And looking at the patient. And the average ER physician loses 3 to 4 hours of his shift a day dealing with the things that we're trying to get rid of. Freeing the doctor up to see the patient, and maybe seeing even more patients.
Yeah.
He's just tied up so long.
I did a lot of consulting for the Department of Defense with the Navy, since everyone knows that I was with the Navy. And I was called down to an emergency department, and I won't say where, but one of the first things we did was we studied to see we actually put stopwatches, so to speak, on what people were spending their time in. And we found that the doctors, first of all, they had astronomical weight, and they were backed up, and had this typical DOD record. And I walked in, sat down with them, started looking at what they were doing, and realized that they were spending half of their time. We documented half of their time looking at the screen. And I said, this has got to change. And by implementing a few things like what you're talking about, we were able to cut that time down dramatically.
Right.
Award-winningly dramatically.
Right.
Yeah.
And it only takes about 45 seconds to get a history of personnel.
We usually use these in documentation lectures. But we just brought to you today if you want to peruse through it and get some tips and tricks.
When you and I dictated charts,
give us a call and see
we could probably dictate a complete chart thoroughly from beginning to end in less than 2 or 3 minutes.
Right. Because you understood what the problem was. Right. The guy has belly pain, but we have to make sure that he doesn't have, X, Y, Z along with it. And once I've ruled that out, then I'm confident that, this is functional pain.
And the computer puts too much information in front of our faces that we have to weed out what we're seeing. And it's just, you're a doctor, you've been trained, use your training and not the computer to help you document it correctly, like what you're going to do for the patient. Right? You need to get a completely different mindset. Yep. And that way, it will free you, the hospital, the emergency room, up some time, precious time, to get away from the doctors being transcriptionists, basically what we are. Yep. Why would we spend all this time in college, medical school, and postdoctorate training to become a transcriptionist? That's what was so insane about this when it all first started.
I saw radiology has standard transcription.
Right, templates.
Okay.
Right.
And the other night, I didn't get too deep into the details of it, but I was trying to make sure that an ultrasound didn't have a DVT and the opportunities. Well, the radiologist dictated this whole thing. Clicked
6-page documentation
on the ultrasound of the carotids.
Right.
Oh, it wasn't the carotids.
Wasn't the carotids. That's not what you're even looking for. And it's not their fault. They're just flashing too much information. Did you remember to do this?
Yeah,
Did you remember to do that?
The interesting thing about that is when you do that, you get paid for it.
You get paid better for it because the coding industry will understand why the patient's there.
We got to scan
what you thought about doing, why you did it, what you ordered. The results were documented. The differential was documented, and the treatment was documented, and the patient's either discharged or sent home. And so it's we got to get back to basics. We've just been swarmed with too much information.
Paul, thanks a lot.
You're welcome.
And
Thank you. Appreciate it.
Thanks, everybody.
Thank you.